So one of the things that I've been able to be a part of during the COVID era is an effort that was initiated by Marina Garassino in Milan, who at the time, Milan was one of the cities most impacted. And she really felt that she needed to learn from her colleagues and share what she knew, what were the best ways to help her cancer patients. And so she reached out to a group of us globally to ask that question, as we had been exchanging information amongst each other informally about how to best go through things. And she was the one who helped me know to early on separate our teams, and the telehealth was something I learned a lot about from her as well. But Leora Horn from Vanderbilt, and she really took on the key leadership roles. Leora working with one of her colleagues to develop a database in REDCap, which is it's a secure system so that the confidentiality is maintained, and then sent out a global ask to many different people to say, hey, if you are seeing lung cancer patients who have COVID-19, could you please participate in this registry? And then we built the database working together, which includes a lot of information about demographics, as well as about what cancer treatments the patients are getting, as well as about what COVID-19 treatments the patients are getting, along with if they're hospitalized, what hospital course do they have. And then Dr. Garassino was able to present the first analysis on 200 patients at the virtual AACR meeting. And it was really well received, and I think quite amazing to see how this went together from her idea to her being able to present on 200 patients within about a month. And of course, we've been continuing to gather data. The initial presentation were mostly patients in Europe, as that had been one of the bigger early waves, and a lot from Italy and Spain and France, but with some of the US patients. And now we're expanding with more of the US patients, obviously have reached out to Asia as well, keeping in mind that even though the first waves of the pandemic were in Asia, because of the policies that were put in place in many Asian countries early, they haven't had the same impact on mortality that has been experienced by Europe and the US. And so obviously it's a registry, and so there are going to be challenges with that, and that which patients get included, who's tested. And testing, of course, in the US and Europe has been highly variable. There are a few regions where asymptomatic patients are being tested. In my own institution now, all the care providers and all patients starting treatment are being tested because we have capacity. But obviously that wasn't the luxury in most places early on. So most of the patients in the database so far are patients who were ill, therefore were tested. And many of them were hospitalized. And unfortunately, we did report a fairly high mortality rate for the patients with lung cancer who caught COVID, who ended up being hospitalized. One of the questions that also came up in healthcare systems that are overwhelmed, if you're dealing in a situation where you cannot possibly put everyone in an ICU who needs potentially to be in an ICU, how do you make those decisions? And so it's very difficult, again, in registry to really understand the nuances there, but some concerns were raised that at least in some of the centers in Europe, very difficult decisions had been made that patients with advanced cancer in a place where there were very, very few ICU beds were not offered those opportunities necessarily. Again, lots of nuances. We're trying to understand it better by going in and digging more and asking more questions to see, are there things that we can learn from those experiences to either say, yes, those decisions, as hard as they were justified, or were perhaps decisions made that didn't need to be made if there were patients who could have recovered. And really, really tough questions. And that's going to be sort of the next wave. So we're also looking at, did the specific cancer treatments impact outcome? And I alluded to that earlier, but it seems that it didn't, that patients with lung cancer, regardless of what treatment they were on, were at risk of having worse outcomes. And that's very unfortunate, and we're trying to understand more from that. But it also tells us we shouldn't avoid the best treatments for our patients merely to try to avoid them getting COVID. So we need to be careful to avoid COVID in all of our cancer patients. And I think that's why there's so much testing and very strict masking and distancing being done in the cancer centers. If a patient does end up with COVID who also has lung cancer, how do we then manage to treat their cancer and give them the best appropriate care to give them the best chance of recovery from COVID? And we're hoping as this database grows, and it should reach somewhere in the thousands of patients, we'll be able to really have learned quite a bit. And so we're going to be having, Dr. Horn is going to be presenting some further updates on the treatment at ASCO. And then as it expands, we're hoping to be able to continue to give updates and publish on this. I think this database is designed as being very specific to COVID. I think there's a lot that the world has learned in the last few months that are applicable to any future pandemic. Hope that that never happens. I think the subtle, that this particular virus is a very difficult virus because of the asymptomatic shedding and spread of disease. I think that's what was the hardest, is that paradigm that yes, completely healthy looking people can be spreading the virus, was one that took a while for us to wrap our heads around. And then the fact that some people can have absolutely no symptoms at all, be perfectly healthy, and another person who otherwise looks very similar can have a rapidly fatal course. That's something else we're trying to understand, and exactly what the virus does to damage so many different organ systems. And we're getting there, but there's still a lot. And also the whole immune response to it, where for some people, they don't even necessarily have antibodies after they've had the disease and it's gone. And other people, their immune system goes haywire and they end up dying from this massive inflammatory process. So much, much more to learn. It's wonderful that so many of the world's brightest minds are working on this problem right now. And hopefully some of what we learn will help if there were to be a future issue. But I think a lot of it's going to be very unique to this virus.